After watching this video, you should be able to describe the basics of the adrenal cortex, starting with the three major zones, feedback control loops, and putting it all together with some clinical applications of excess and deficiency. So let's get started and look at the different zones of the adrenal cortex. We can see here that there's three principal zones. Starting on the outside, working our way in, we have the glomerulosa, followed by the fasciculata, and then finally the innermost layer of the adrenal cortex, the reticularis. Now, what we have here are some classifications of the major hormone that's coming out of these zones and important regulators. So starting with the zona glomerulosa here, which is the outer layer of the adrenal cortex, we can see that aldosterone is the principal hormone made by the zona glomerulosa. Now, if you want a way to remember this, we know that aldosterone's primary effects, not all of its effects, but most of its effects, are in the kidney, particularly the collecting duct. Now, glomerulosa has in its name, it sort of sounds like glomerulus, and that's the capillary bed that's distinct for the kidney. So that's a little mnemonic to help us remember that the hormone coming out of the zona glomerulosa primarily acts in the kidney, and that would be aldosterone. Now, the major regulators of aldosterone turn out to be the angiotensin II that's made by the renin-angiotensin system, and the principal receptor that angiotensin II acts on that's very important is the angiotensin II type 1 receptor, which happens to be a target of a major class of drugs called angiotensin receptor blockers, which we'll talk about in another video. Also, plasma potassium levels has a direct effect as well on the zona glomerulosa. So you can see here that these are the principal regulators of aldosterone secretion by the zona glomerulosa, and that'll be important when we're talking about feedback control. Now, the next two layers, the fasciculata and reticularis, often are just thought of as a functional unit. And actually, a lot of people sometimes just think that they're both doing basically the same thing, and they're both making the same hormones and are regulated in the same way. Sometimes it's nice to separate them to try to help remember what's going on. And so what I did here was I separated fasciculata and reticularis and said here, well, fasciculata, let's say, is mostly making cortisol, and the reticularis is mostly making androgen. But you might see as you read in different places, sometimes these are just combined together. For this video, we're going to separate them. Okay, so we have cortisol coming out of the fasciculata, and again, androgens coming out of the reticularis. Now, it's important to remember that it's not just any androgen coming out of the reticularis. It's actually these what so-called adrenal androgens, DHEA, sulfated DHEA, and androstenedione. Okay, very little testosterone, dihydrotestosterone is made by the adrenal cortex. These are principally what are made, and actually, quantitatively, the DHEA sulfate is mostly what the adrenal cortex is putting out, with to a lesser extent androstenedione. Qualitatively, the androstenedione is more important because, of course, it's one step closer to making testosterone. This is important because if you're trying to assess someone who has suspected androgen excess, particularly let's say it's a female patient, and you're not sure, well, is that extra androgen excess that I'm seeing, hirsutism, acne, reproductive issues, is that extra androgen that's suspected, is that coming from, is it an ovarian source or is it an adrenal source? It's very important to think about these DHEA sulfate levels, because if you measure those, that gives you a little bit of a clue about where the excess androgen is coming from. And so that's important in terms of lab testing. At any rate, both of these hormone classes are both regulated by ACTH. Okay, so the thought is that ACTH, adrenal corticotropin hormone, that's coming out of the corticotrophs of the anterior pituitary, acts on ACTH receptors that are found on the fasciculata and reticularis and stimulates steroid hormone synthesis. Okay, probably what's happening is the ACTH working through its receptor, which we've labeled here ACTH receptor, or sometimes it's referred to as the melanocortin 2 receptor. Increases cyclic AMP and pKa, and then that leads to phosphorylation events that causes upregulation of LDL receptors, which helps those cells take in more cholesterol, Probably also effects on intracellular cholesterol handling, like cholesterol esterases and such. And the increase in cholesterol in these cells results in the increase in synthesis. As we know, the cholesterol can go into the mitochondria and get acted upon by side chain cleavage and make these steroid hormones. Okay. Now, another thing that's important to know, and I put a star here by it, is that ACTH is trophic for these particular zones. And what that means is that if ACTH is chronically high, these zones will increase in size and number. Okay? And on the other hand, if ACTH is deficient over time, these zones could atrophy. Okay? So these two zones in particular are very sensitive in terms of trophic effects to ACTH. Now, what I don't have listed here, remember this is major regulators, is that ACTH can also stimulate the glomerulosa cells a little bit. They do have ACTH receptors, but it's not a major regulator, and generally it's not terribly important to think about ACTH acting on the glomerulosa cells. It's better to think of just these two zones here. Okay? So now that we've gone over the major zones, let's take a look at the synthesis of these hormones as a review from another video. Okay, so what we're going to do here is take a look at this, which is a slide that we discussed in the steroidogenesis lecture. Okay, and I want to point your attention to a couple of things here. Okay, so aldosterone, we said, was made in the zona glomerulosa, and that means that the zona glomerulosa, of course, would have the side chain cleavage enzyme, the 3-beta-HSD isomerase enzyme, right, to make progesterone, and then it's going to flow down over here on the left, right, to 11-DOC with 21-hydroxylation, and then aldosterone synthase is, of course, going to be in this zone. It's going to hydroxylate 11-DOC to make corticosterone, then it's going to have a hydroxylation at the 18th carbon and then an oxidation, and then we have aldosterone. So it's important to recognize here that aldosterone that's made by the zona glomerulosa, you have to have these enzymes, okay? And also that the zona glomerulosa doesn't make any of these other hormones, cortisol or androgens, because it doesn't have the 17-hydroxylation step, right? It doesn't have the P450C17. So the zona glomerulosa is pretty unique. It only has the aldosterone synthase enzyme in addition to these other enzymes, okay? And it doesn't have 17-hydroxylase activity, okay? And that's why it makes principally aldosterone. Now for the other zones, okay, if we wanted to simplify things in our mind and say, well, the zona fasciculata makes cortisol, then we would imagine that this pathway would flow down to cortisol. We would have 17-hydroxylase in addition to side chain cleavage, the 3-beta-HSD isomerase, 21-hydroxylase, and then of course the 11-hydroxylation, okay, to make cortisol. All right. Now if you want to make androgens, then what's going to happen is you're going to flow all the way to the right. You're going to still have your side chain cleavage. You're still going to have the 3-beta-HSD isomerase. And then you're going to have the 17-hydroxylase in addition to the 17-20 lyase. Okay, and remember, the way to think about and remember these enzyme names and steps, we want to think about what these structures look like. And again, this is review from the steroid synthesis lecture. We can see here that in order to make cortisol, we need the 3-beta-HSD isomerase. We need a 17-hydroxylation, a 21-hydroxylation, and an 11-hydroxylation. Okay, and you can see that for aldosterone, very similar pattern, except no 17-hydroxylation, and then we have that 18-hydroxylation and 18-oxidase oxidation at the 18th carbon. And then an important difference is that you see these androgens here. Let's just look at testosterone, even though it's not really being made by the adrenal cortex so much. The key thing here with these androgens, all right, which also lead to estrogens, is that they have 2 less carbons because of the 17-20 lyase activity. Okay, so that's just a quick review of the steroidogenesis that'll be important when we talk about enzyme defects. Okay, and I also want to point out one other thing, just going back one last time to the steroid synthesis pathway. Keep in mind here that the 21-hydroxylase enzyme is found both in the glomerulosa and also in the synthesis of cortisol. Okay, and so you can imagine that if you have a 21 hydroxylase defect, not only would you affect cortisol, but potentially, if it's severe enough, you can also have a deficiency in aldosterone. So it's really important to keep in mind where these enzymes are and what they're doing. All right. So now let's take a look at feedback. All right. And this is the standard way that we do feedback. We have boxes and arrows. Okay. And we will start here with the hypothalamic pituitary adrenal axis, the so-called HPA axis. So the hypothalamus secretes corticotropin releasing hormone into the portal circulation, remember in the hypothalamus video, and the CRH then binds to CRH receptors on the corticotropes in the anterior pituitary, activates those cells to increase secretion of adrenal corticotropin hormone, or ACTH, which primarily acts on the zona fasciculata and reticularis, like we said, doing two things: increasing steroid synthesis by increasing cholesterol in those cells, which is the precursor to steroids, and also having its trophic effects. And then we can see here that we have cortisol coming out, which is our glucocorticoid, and then we have our adrenal androgens, DHEA, sulfated DHEA, and androstenedione. Okay. Now look at this, the way this is set up here. The cortisol is going to have its biological effects, of course, through the glucocorticoid receptor. But look, it's the only output that's coming back to have negative feedback. So what that means is that the corticotropes and hypothalamic cells that make CRH, they have glucocorticoid receptors that respond to cortisol, and that's how cortisol exerts negative feedback on the system. Now, even though adrenal androgens are coming out here, notice that they're not coming back and exerting negative feedback. And that's actually important, because if you happen to have excess of these androgens for some reason, maybe it's a tumor making them, or coming from somewhere else, that would not have any negative feedback on this system. Okay, so that's an important consideration. Now there's one other little thing that we have here that's clinically relevant. ACTH structurally has a string of amino acids that's very similar, or really identical, to alpha melanocyte stimulating hormone. Okay, so the precursor for ACTH, called POMC, okay, ends up having, when it gets cleaved, some amino acids that makes it very similar to a hormone that can stimulate melanocytes in the skin and cause skin darkening. Okay. Now, because ACTH is not exactly that hormone, it doesn't really have a high affinity for these receptors. Okay, so only in cases where ACTH is really high, it can stimulate skin pigmentation. Now, this is dotted line. This is not to imply it's inhibiting, actually. This is just to imply that it's a weak effect, that ACTH has a low affinity for these receptors in the skin. And it's only when in excess that you can actually get generalized skin hyperpigmentation. So keep that in mind when we're thinking about disorders where this could be high. That's something that could show up clinically in a patient. Okay? Now, over here on the right, we have the zona glomerulosa segregated in feedback as a different feedback loop, because remember, it's not really regulated by ACTH. Okay? Now, look what we have here. We have the adrenal cortex being stimulated by angiotensin II, and remember the receptor is the AT1 receptor, and also plasma potassium can stimulate the zona glomerulosa as well. Now, when aldosterone comes out, we've summarized it all with one big arrow here. Aldosterone's effects in the kidney to cause salt and water retention results in an increase in blood pressure. Okay, so when aldosterone goes up, that causes blood pressure to go up. Okay, now if blood pressure goes up, there's some mechanisms that we're not going to go into detail here that causes suppression of the cells that secrete the enzyme renin. And this is through a variety of different mechanisms. One of them would be these renal baroreceptors. Another one could be through effects on the sympathetic nervous system. And we've just summarized that here with a negative sign. Okay, so blood pressure goes up, that should have a suppressing effect on renin secretion. Okay, and if blood pressure goes down, then renin secretion should go up. Okay, now renin, through a variety of different steps that's just summarized here with a couple of arrows, converts angiotensinogen to angiotensin 1, and then angiotensin 1 goes to angiotensin 2 through the enzyme angiotensin converting enzyme. And all that will be discussed in another video. We're just summarizing it all here with, if renin goes up, that results in an increase in angiotensin 2. Okay, now we also know that aldosterone, through its effects on the kidney, increasing salt and water retention, causes also a increased secretion of potassium, also a hydrogen ions, which isn't shown here. And if aldosterone goes up, that causes plasma potassium to go down because you're increasing potassium excretion by the kidney. If aldosterone goes down, then potassium levels will go up, okay, because of the potassium retention. Okay, so that's why there's a negative sign here. So look, there's two parallel negative feedback loops. You follow the aldosterone blood pressure renin loop with the angiotensin, there's one inversion. There's an odd number of negative signs. If you follow the plasma potassium, which is this little tiny loop here, there's one inversion. Odd number of inversions is a negative feedback loop. So these are two parallel negative feedback loops that work. Okay, so now what we're going to do is we're going to put it all together and we're going to try some clinical applications of deficiency in excess states. Now, it's not going to be complete, but it's a good thing to work through. All right, so what we have here is we set up a grid of some different things that you might be measuring in a patient. Now, it doesn't have everything, but it has a lot of stuff that we can use with our feedback loop. All right, so let's start with what we have here called severe 21-hydroxylase deficiency. The reason why I wrote that is that this particular enzyme defect comes in some different flavors. You can have one that's not as severe. And what this is really implying is that it's severe enough that it's affecting all the zones that it could in the adrenal cortex. Okay? So let's start with where we would have the problem in our feedback loop. Okay, with a 21-hydroxylase defect. So if we go over here, okay, of course, what we're going to have a problem in the synthesis of cortisol, because remember, 21-hydroxylase is a key step in the synthesis of cortisol. And we're also going to have a problem if it's severe, right? We're also going to have a problem making aldosterone, because remember, aldosterone and cortisol both have hydroxylations of their 21st carbon, as we saw in their chemical structure. Okay, so if we go back to our grid, our table that we're going to fill out, where would we start? We would start at cortisol going down, okay, and in addition, aldosterone going down. Okay, so we can put a little 1 there if we like, so we know where we're starting. Okay, now depending on where you want to go, you can go to different directions. Okay, so one pathway that we could start with is, well, if cortisol is low, because there's lack of negative feedback on the corticotropes, we know that ACTH should be increased. Okay, now if ACTH is increased, it's going to increase cholesterol inside the Fasciculata and Reticularis, and you're going to start shunting the precursors towards the only available pathway, which would be androgens. And in this case, the only androgen we have is DHEA sulfate. Okay, so that would go up. Okay, so what we've done is we've taken care of the hypothalamic pituitary axis, thinking about what would happen there. Now, with aldosterone being low and also cortisol being low, both of these hormones can affect blood pressure and increase it. So we know that the blood pressure should be down. Okay. And if the aldosterone is low as well, okay, the potassium should be increased, okay? And the blood pressure being low, remember, is going to be a stimulation effect on the cells that secrete renin. So plasma renin activity should be increased, okay? So that's what that pattern generally would look like if you were just going to work on the feedback loop that we have. It's not always true that things are going to work out exactly this way with blood pressure, potassium, but in this case, the enzyme defect is so severe that this is what we would expect. Okay. Now let's take a look at the 17-hydroxylase defect. Now 17-hydroxylase, remember, is necessary to make cortisol. Right? So cortisol is going to definitely go down. Okay? Definitely going to have that be decreased. Now, we might need to go back, sometimes it's easy to forget. We might need to go back to our steroid synthesis pathway and go, all right, well, 17-hydroxylase is not part of the zona glomerulosa at all, right? 17-hydroxylase is important in making cortisol and androgens. So we know that our cortisol is going to be down. We're also going to have trouble making sex steroids. That's going to be down as well, okay? And if we were looking at the gonads, which isn't shown here, of course the gonads also need 17-hydroxylase. So there would also be not only an effect of this enzyme defect in the adrenal cortex, but it also would be a problem in the testes and ovaries as well, because you need 17-hydroxylase in the gonads to make those sex steroids as well. So that's something that's also important, that this enzyme defect would not be completely restricted to the adrenal cortex. All right, so we go back to our table that we're filling out. So we know that cortisol will be down. We also have decreased sex steroids. Okay, so that would we can put a 1 there too. All right, and we know that ACTH is going to be increased from lack of negative feedback, all right, from cortisol on the glucocorticoid receptors in the hypothalamus and pituitary, all right. And now things get a little interesting, all right. Because ACTH is causing stimulation of the adrenal cortex, all right, we're going to end up with an accumulation of that hormone 11-deoxycorticosterone, which isn't shown here. And 11-deoxycorticosterone has mineralocorticoid activity. So we're going to end up with an increase in blood pressure and a decrease in potassium, okay? And this is probably from an increase in 11-DOC that's going to accumulate. Remember, this has mineralocorticoid activity if you get it increased in the plasma enough. Enough free levels can activate mineralocorticoid receptors. So as a consequence of the blood pressure being high, we would maybe expect that the plasmarenin would go down, and of course the aldosterone would go down. So the aldosterone is not decreased because we're not making it because of the enzyme defect. It's actually through negative feedback from the blood pressure and potassium those changes were from an increase of another hormone that accumulated. Okay, and that would be just a general thing that we would expect from the feedback loop that we're using. If we have a 17-hydroxylase defect. 11-hydroxylase defect. Well, of course, we need that to make cortisol. All right, we definitely need it to make that. Now, if we go to our steroid synthesis again, oftentimes we need to take a look at it in our mind to figure out what's going to happen. With an 11-hydroxylase deficiency, you can see that you're not going to really have a problem making these androgens here. Okay. And it wouldn't be a problem in the zona glomerulosa because it has its own 11-hydroxylase form and P450 aldo. So that's not defective. It would just be this enzyme here. Okay, so we go back to our clinical problem solving here. We know that what would happen is because cortisol is down, there's going to be an increase in ACTH. Okay, that's going to cause an increase in LDL receptors, cholesterol release from cholesterol esters. You're going to get an increase in synthesis of precursors. And in the zona fasciculata and reticularis, you're going to get ACTH stimulation, okay, because those receptors are there. And the only pathway to go is to make androgens, so that's going to go up, okay. In this case, the DHEA sulfate, all right. And we have a similar problem with the 11-hydroxylase defect. Okay, we're going to have an increase in blood pressure and a decrease in potassium. Probably this is from going to be the 11-DOC, right? And that would increase as well because remember the 11-hydroxylase works on the 11-DOC. So as a consequence of that, we would expect that the plasmarenin would be suppressed and the aldosterone would be suppressed. Okay, in theory. Okay, and so again, the aldosterone is not affected directly by these enzyme defects, but through feedback by another hormone acting at the mineralocorticoid receptor, we would have that profile. Now, before we move on to these other examples, I want to just point out some things here. Do you see that these three defects, they have something all in common, right? They have this profile here, right? A problem in making cortisol, and because of lack of negative feedback, an increase in ACTH. And These three enzyme defects are part of a family of disorders called congenital adrenal hyperplasias. Okay, congenital because there's an enzyme defect someone's born with. Adrenal hyperplasia is referring to the zona fasciculata and reticularis that's being overstimulated by the ACTH. It's causing an increase in those zones in the size. Okay, and they're going to have, of course, symptoms of varying degrees of cortisol deficiency. Now that's really all they have in common. If you go and look at what else is going on here, there's some differences, right? You can see that in the case where there's an increase in androgens here, right? That could be a problem for a female fetus, right? You'd have masculinization and virilization potentially from the increase in androgens of a female fetus, and these enzyme defects that are occurring, if they're occurring in an XX fetus, a female fetus, you get something called female pseudohermaphroditism. Okay, because you'd have ambiguous masculinized genitalia, and you see here that if you have a problem making sex steroids, that in a male fetus you get a male pseudohermaphroditism, right? Because the male fetus would not be getting the androgens to masculinize the genitalia, and so you get some interesting things here that we'll discuss in a specific video on these congenital adrenal hyperplasias. But it's important to recognize that these different problems with sexual development, sexual characteristics, and external genitalia are going to be affected by changes in these sex steroid production. Also, you can see here that there's interesting things on blood pressure where you have hypertension and hypokalemia potentially when you have these conditions that increase 11-DOC. And again, we'll talk about that more specifically in our congenital adrenal hyperplasia videos. Okay, so I just wanted to point that out. Now, if we go and look at adrenal cortex destruction by an autoimmune process, which is the most common cause of Addison's disease now, at least in the United States, we can see that all of our hormones are going to go down that are in the adrenal gland, adrenal cortex rather. You're going to have cortisol, androgens, and aldosterone, right? They're all going to be knocked out because of this autoimmune process. And as a consequence of lack of negative feedback from cortisol, we're going to get an increase in ACTH. If we have aldosterone low and cortisol low, we're going to have low blood pressure, so the blood pressure is going to be low. We might have, of course, lack of aldosterone's effects on potassium, so we're going to have an increase in potassium, and we would expect that the plasma renin would go up, okay, using our feedback loop. Okay, and so this would be a very serious condition, profound loss of cortisol and aldosterone, which could be a medical emergency. Okay, so that would be how we would figure out loss of all zones of the adrenal cortex. One other little side note is that if a patient has this and the ACTH is up there long enough, remember, because of the ACTH's affinity for the melanocyte stimulating hormone receptor on skin, these patients can develop generalized skin hyperpigmentation, which again we'll talk about in other videos in more detail. We also can have an ACTH secreting tumor where there's lots of ACTH coming out. Now, of course, that could be from a corticotroph tumor, right, an adenoma, or it could even be an ectopic source, like a lung tumor, for example, making lots of ACTH. It doesn't really matter in this case for this exercise where the ACTH is coming from. We know that it's high. So we're going to start out with ACTH being high. Now, we know if ACTH is high that we're going to get an increase in cortisol, and we're going to get an increase in DHEA. All right? Now, this is sometimes clinically, this is not going to really work out exactly how we have this here all the time, but for the purposes of this video, let's just say that because of the increase in cortisol, cortisol does have an effect on blood pressure to increase it, all right? The blood pressure is going to be increased. Okay, now of course if you had blood pressure data, you would confirm that. Now, what we can do with our feedback loop is we can say, well, if the blood pressure is increased, okay, then we're going to have a decrease in plasma renin activity, okay, and we're going to have a decrease in aldosterone, potentially, okay. Now, what we also might expect is some effects on potassium. Now, this gets a little confusing, actually, because cortisol actually has mineralocorticoid receptor effects if it's in high enough levels, and you could get some cortisol having effects on the mineralocorticoid receptor, and you could also have a little bit increased DOC production with this increased ACTH stimulation. So this is going to be down here, probably, but there is some variability on how this presents. Let's just say for this video that the reason why we're having this profile is, let's just say cortisol in excess is saturating the 11 beta HSD2 in the kidney, and you're getting mineralocorticoid effects from the cortisol, and maybe even a little bit of increase in DOC. Okay? But the key thing here is that cortisol is going to be increased, and the DHEA sulfate is going to be increased because ACTH stimulates those hormones. Okay? Now, if we have an aldosterone secreting tumor, well, of course, we're going to start with aldosterone. That's going to be increased. Okay? And if aldosterone is increased, well, then you're going to get aldosterone effects. So you're going to have increase in blood pressure, and you're going to have a decrease in potassium. And the increase in blood pressure and decreased potassium, that's going to cause suppression of aldosterone if this was from feedback. But because aldosterone is the problem, there's a tumor maybe of the zona glomerulosa that's making lots of this stuff, the blood pressure and potassium will not feed back on aldosterone, and aldosterone will still be high. That's why we put a 1 here, because that's where the problem actually lies. Now, the high blood pressure, remember, is going to suppress renin, so that's going to be low, okay, potentially. And that's really what the abnormalities would be here. If you look at what ACTH would be doing, and what cortisol would be doing, and what DHEA sulfate would be doing, these are not regulated by, they're not going to be certainly suppressed by an increase in blood pressure. Sometimes, a low blood pressure, if it's like hemorrhage, that's really a stressor, and you can get a turning on of the CRH, ACTH, cortisol axis. But in this case, the blood pressure going up, there is no inhibitory feedback from blood pressure on the HPA axis. So you can see that these really would be normal. The primary abnormalities would be in the aldosterone axis at the zona glomerulosa. Okay, so if you can work out these arrows by working out this feedback loop, that's really what you want to be able to do. Okay, and remember, when you're doing these, you want to start with where the problem is, right? So if it's a zona glomerulosa tumor making aldosterone, you start there, okay? If it's a ACTH tumor, you start with high ACTH, right? If you damage the adrenal cortex, you start with the low levels of cortisol and androgens and also aldosterone. If you have enzyme defects, you start with, well, what hormones are going to be affected by that enzyme defect, and then work your way around. Okay, so I would recommend when you're working out these clinical problems, I would draw these feedback loops and then put in the specific disturbance and work your way around to figure out what's going on. Okay, and it's a really important thing because you're going to be dealing with patients that have signs of excess or deficiency, and you want to be able to predict what these hormones are going to be doing. Okay. So now if we go back to where we started here, we talked about the different zones, the zona glomerulosa, zona fasciculata, zona reticularis. We reviewed the steroid hormone synthesis pathways, which are very important in predicting enzyme defects. We went through the feedback control loops, somewhat simplified, to be able to apply it to clinical applications. We talked about some important enzyme deficiencies. We talked about some tumors, and even autoimmune destruction of the adrenal gland, which are all very important disorders that we'll discuss in other videos. And that concludes this video on the adrenal cortex.